right, welcome back. Part 2. I want to talk about the different types of STEMIs and the different things you will actually see depending upon where the blockage is. Now, before we get too deep into this, I just want to throw one caveat out there. Human beings are not anatomically identical. So different ones among us have different blood vessels perfusing different parts of our heart. One common statistic I use is that 15% of your inferior MIs can actually be due to a blocked left circumflex, not right coronary artery. Those are the numbers. We are all a little bit different here and there, but you know a lot of times you can see an inferior wall MI, or at least 15% of the time you can, and it can be a left circumflex artery blockage, which usually presents as a lateral, but in that particular case it doesn't. So that's the one caveat. These are the usual suspects. So when we see an anterior MI or septal wall MI, we anticipate that the left anterior descending is blocked. And when we see an inferior wall MI, we anticipate that the right coronary artery is blocked. And when we see a lateral or a high lateral MI, we anticipate that the left circumflex is blocked. We're not going to cover left main coronary artery occlusion in this one. That is not the best studied case in the world, so to speak, and it usually does not result in a bunch of very specific ST elevation that we can just pick out on an EKG and say, bam, that's an LMCA occlusion. So we're just going to study the three big types of STEMIs based on the three main coronary arteries and how this usually presents. All right, so different STEMIs will present with different problems. We're going to look at a rundown of the common presentations that are unique to each area of infarct, and please understand that this is by no means 100% concrete. There are lots of things that color outside the lines when it comes to patient presentation. That's why we have terms like atypical presentation, right? We're going to start with the anterior MI. So this is leads V2 through V4. You can actually see lateral involvement in very large MIs, so V5 and V6 can also be affected. When ST elevation is in leads V1 and V2, the septal wall is usually involved. Your conduction system may also be involved in these, so that's a little bit counterintuitive, right? Usually when we talk about conduction system, we're looking for right coronary artery blockage. This is one of those times where this can kind of color outside those lines. So anticipate a high degree heart block. It doesn't mean it's going to happen. It means you need to be ready for it. Any new onset nerve blocks may be seen with STEMIs, so with these types of STEMIs. So that means that it is not unusual to see a left bundle branch block, a right bundle branch block, a left anterior or posterior hemiblock. Any of those result in these, okay? Usually you're going to see a decrease in blood pressure and an increase in heart rate with these types of MIs. But one very noteworthy thing is, as we live longer, we have heart attacks later in life. So your patients that are on beta blockers, particularly the heavy duty beta blockers, may not present with tachycardia. So their heart may not be able to give you those rates that you're used to seeing. Anybody with beats in the range of 80 to 90 a minute, though, you need to consider that tachycardic when they're on those heavy hitting beta blockers for blood pressure. Okay. So here we have an anterior STEMI. So as you can see, V2, V3, and V4. These have a pretty good amount of involvement. You can also see one in AVL. There is lateral involvement in this. Now, this is sort of a chicken or the egg deal. I don't know if the lateral is causing the elevation in the precordial leads or vice versa, but the entirety of those areas are ischemic. So this is a very large MI in the heart. And as you can see, you have inferior reciprocal depression, 2-3 in AVF. So it's obvious here this is a very large STEMI and it has anterior involvement, so this is something you might expect to see. All right, let's move on to the inferior MI. Usually the right coronary artery is involved when we're talking inferior MI. Now, conduction disturbances are very common, especially AV blocks when it comes to the inferior MI. Because the right coronary artery is really one of the sole feeders of the conduction system, the SA and the AV node are commonly affected, all right? If there is right ventricular involvement, you may see jugular vein distension. You may see a backup of blood into, the right side circuit of things, and that involves the venous circuit. Generally, in terms of patient outcomes, it's tolerated better than the anterior MI. So just in terms of morbidity and mortality, the statistics show people tend to live a little more or to do a little better with an inferior MI. Up to 40% of these cases have right side involvement. So when we say right side, we're talking about right ventricle. Right ventricular involvement in an inferior MI is very important to diagnose. That means your patient is preload dependent when that is going on. So this is not a patient who can have nitro right out of the gate if they have right ventricular involvement. You will have to fluid load this person in order to administer nitroglycerin to them safely in the pre-hospital setting. One of the biggest reasons for that is the amount of nitro we use, right? So we give 400 micrograms of nitro every time we spray under the tongue or we put a pill under someone's tongue. That's not quite the case with a nitroglycerin drip, but there are not many pre-hospital services that are using nitroglycerin infusions in the setting of acute MI in terms of, bedside or street side. So that's one thing you need to think about. The nitrates are usually contraindicated unless you do some fluid loading, and you need to know how to do it, and you need to be prepared for cardiac arrest. So this is not something you go off half-cocked and do. You need to obey your local protocols, work with your medical director, and make sure you have the training before you attempt to do something like that, because it can end poorly if you do not. With ST elevation in V1, you can I don't want to say assume, but very often this indicates right side involvement. So this is sort of a way we can look and anticipate right side involvement prior to doing V4R. With that said, there is no substitute for V4R or for doing a right side ECG. You should always be doing those on an inferior MI. These are just a couple of cues, these 3 cues on the screen that can help you clue in to the fact that you're probably dealing with a very large MI. The reason it's important to know this or to attempt to glean it from a normal 12 lead ECG prior to doing the 15 lead is because when you see this kind of stuff, rather than taking time to move leads and to interpret more tracings, you would be better served to put your defib pads on, to initiate a large bore IV, to get prepared for cardiac arrest, and then you can check the right ventricle. Because at the end of the day, it doesn't matter if this is a right-sided MI. If they go into cardiac arrest, the algorithm is the same. You need to be prepared for that. And as we all know, or should know, every minute that goes by without proper CPR or defibrillation in cardiac arrest decreases a person's chance of living up to 10%. So you're better served to be more prepared for cardiac arrest. And this is one of the ways you can do it. You can take a look at these 3 things on the screen. So the second one is ST elevation. It is greater in lead 3 than the ST elevation in lead 2. This usually indicates a more distal occlusion, which means it's much more likely to involve the right ventricle at that point. Also, if you have descending QRS height in leads 3, 2, and 1. So let me say it again. If you have descending QRS heights in leads 3, 2, and 1, that's a giant red flag, okay? A giant red flag for there is more than likely right-sided involvement. Let me take a quick timeout, put the defib pads on, get the IVs in, get everything ready for cardiac arrest. Then we'll do a right-sided. Then we'll work on nitro, that kind of thing. Never let your ALS get in the way of your BLS, right? And we all know that. So this is a beautiful inferior MI. As you can see, you've got lots of elevation in 2, 3, and AVF. You've got reciprocal depression in lead 1 and AVL. Not a ton of other stuff going on except for, obviously V4, V5, and V6. That is showing right-sided involvement. So they have moved all 3 of those electrodes to the right side. And as you can see, that massive amount of elevation, you definitely have right ventricular involvement in this one, okay? This is another example. So different EKG, different patient. Another example. It's got some of the red flags we just talked about on here that you can see and just kind of familiarize yourself with. Feel free to pause the video and just kind of pour over this EKG and go through it. All right, so moving to the lateral MI. With the lateral MI, the signs and symptoms are anybody's guess. So there's a lot going on in the lateral MI. With the lateral MI, you can have a blockage anywhere from, the base of the LMCA all the way out to the left circumflex artery. So what is involved in there? Of course, the left atrium, the left ventricle. There is, a lot of times posterior involvement there. So if someone is left circumflex dominant, their left circumflex is going to wrap around the back of the heart and perfuse the posterior wall. So there's a lot of infarct that can happen there. So your signs and symptoms of a large lateral MI may simply be cardiac arrest. They may be tachycardia. They may be jugular vein distension. It may be hypotension. You may get the basal gyrus reflex in there. This is a lot of myocardium that is not being perfused correctly. So with the lateral MI, pay particular attention. And that's not to say that there's not a STEMI that's not important or a transmural MI that's not important. But the lateral MIs, in my case, they make me particularly nervous because I know there is a very large area of myocardium that is infarcted, and that is the area of myocardium that is responsible for making the blood pressure that is perfusing the myocardium. So it's a positive feedback loop, or a cycle, so to speak. So the more compromised it is, the worse off the patient can be. This is a really good EKG, a good example of the lateral wall MI. The reason I like it so much is you can see your elevation in 1 in ABL, you can see your reciprocal depression in 2, 3 in AVF, but it's not huge. We tend to think of STEMIs as more elevation equals worse MI. This is a little bit different than that. This is not one of those EKGs that shows that, but I assure you there's just as much ischemia here as there is in any lateral wall MI. It doesn't have to be 8 or 9 millimeters to be a big MI. These 2 or 3 millimeters, they're all it takes. They're plenty. And as you can see, you've got involvement in V2, V3, V4. There's a lot of compromised myocardium here. So there's the lateral wall MI. All right, that covers types of STEMIs, and I look forward to giving you guys part 3 soon. Thank you.